أعوذ بالله من الشيطان الرجيم
पनाह मांगता हूँ मैं अल्लाह की शैतान मरदूद से।
بسم الله الرحمن الرحيم
शुरू अल्लाह का नाम लेकर जो बड़ा मेहरबान निहायत रहम वाला है।
إذا جاء نصر الله والفتح ورأيت الناس يدخلون في دين الله أفواجا فسبح بحمد ربك واستغفره إنه كان توابا।
जब अल्लाह की मदद आ पहुंची और फतह हासिल हो गई और ए नबी सल्लल्लाहु अलैहि वसल्लम तुमने देख लिया कि लोग फौज दर फौज अल्लाह के दीन में दाखिल हो रहे हैं, तो अपने परवरदिगार की तारीफ के साथ तस्बीह करो और उससे मग़फ़िरत मांगो, बेशक वो बड़ा मुआफ करने वाला है।
Jazakallah. Okay, we are honored to have Professor Rashid Latif Khan, who will chair this webinar. Professor Farooq Zaman as the co-chairperson, and respected faculty members, all the professors, and our guest speakers. I would like to take the opportunity to welcome our guest speakers, Dr. Somia Iqtidar and Professor Saqib Saeed, who have spared the time for us. We will have 5 presentations covering the major aspects of COVID-19, which will be followed by the question and answer session. But due to shortage of time, I would request all the participants to ask their questions through chat during the webinar so that we can, the presenters can answer your questions during the webinar. We have also requested the presenters to please leave their names and emails so the participants can ask them questions even after the webinar. So it would be comfortable, convenient for all of us. We will start with the first speaker, Professor Azizur Rahman, who is going to talk on the pathogenesis and diagnosis of COVID-19. So Professor Azizur Rahman, over to you.
Thank you. Okay. Let me first welcome our patron, my teacher, my mentor, Professor Rashid Latif Khan and Professor Farooq Zaman. And I think Professor Tahir is on his way. And let me also welcome Professor Saqib Saeed, who has been a friend, and he was also a colleague in King Edward Medical University. And my student and my colleague and Dr. Somia Iqtidar, and we often work together. And we also work at this Pakistan Society of Internal Medicine, and Professor Abul Fazal and all the senior faculty members. I really thank you to join, and we are going to talk about a very, very important topic. And when I had this idea, and it was received by many with very, very good response, because it is a very, very important topic. So I am going to give you very, very basic concepts about the disease, but the main components which are important for all of us are going to be covered by Somia and Professor Saqib. And I think because I'm the first speaker, I will go a little beyond pathogenesis and diagnosis of COVID-19, because we have some students also. So I think I will talk about some of the basics of this disease also. Now, why this webinar? And I read this statement on CNN, and I liked it so much that at that time I decided to do this webinar. There is a lot of information, and there is a lot of misinformation also. And a beginner cannot differentiate between the two. So this statement, coronavirus needs a host to spread, and misinformation also needs a host to spread. And you can prevent the spread of both by listening to the experts. And that is why I have called some experts not only in their knowledge, but because they're actually dealing with patients with COVID-19. So whatever you will hear from them is the truth, and everything else is just myth. Terminology: SARS-CoV-2 is the name of the virus. And COVID-19 is the disease which is primarily related to lungs, but it is actually a systemic disease. And it is not simply infection, it is much more complex, and that disease is called COVID-19. And history, very briefly, I'm sure all of you know, this was first time we reported from China, from Wuhan, Hubei province, China. It was first reported to the WHO 31st of December 2019. I'm sure the epidemic was going on for at least a couple of weeks or months. And in Pakistan, the first case was reported on 26th of February, and on 11th March, it was present all over the world, affecting 200 countries. The WHO declared it as pandemic. And some of the stats, the latest stats, in Pakistan, we have approximately 218,000 who are reported confirmed cases. And in the world, we have 11 million confirmed cases. And the mortality in Pakistan, approximately 4.5 thousand, and in the world, more than 500,000 worldwide mortality. So it is spreading widely and it is killing people. And luckily, the percentage of mortality in Pakistan, at least the reported mortality in Pakistan, is around 2%. And in the world today, taking these figures, is around 5%. But in some groups, it may be less. In some groups, it may be high. And we all believe all these figures, they just represent the tip of the iceberg. And officially, CDC announced that actual cases in America may be 24 times more than the reported cases. So I think the situation in Pakistan may be same, if not worse. Now, the mode of transmission, it is basically a respiratory droplet infection, but the virus can stay in the air as aerosol, and after up to 3 hours in the same environment, anybody breathing in the same environment can get the infection. And it can penetrate all mucosal surfaces directly or indirectly. And fortunately enough, at least that is what I know, the virus cannot penetrate intact skin. So we feel very assured from that. So all you have to do, one basic rule of prevention is you have to protect your T-zone. So these are the main mucosal surfaces which provide entry points. Basically nose, mouth, and eyes. Other mucosal surfaces are less prone. So I think if you can safeguard your T-zone, you are protected. Now, the history of this virus, where this virus came from, originated from bat. Bat have these kind of viruses. After some mutation, it probably infected some intermediate host, which is believed to be an anteater, but it is not sure. Again, after certain mutation, and that mutation has been actually identified, it was able to infect a human. And from human to human transmission was possible after the mutation. Then it kept on spreading in an exponential way. Now, there's a term called reproduction ratio. That means on the average, what number of persons are infected from one person. So the number given is 2 to 4. If we assume just 2, and then there's a term called series interval, the time interval taken from one person to another, that is 5 days. So these are the average values. If we assume a reproduction ratio of 2 and series interval of 5 days, you can imagine that one person can infect up to 64 in just 1 month. And this epidemic is now going on for more than 6 months. Now, how do we handle all these people, so many people infected? Luckily, if 100 people, for example, get this infection, most of them, they will remain asymptomatic. They might not even feel the flu symptom, but if at all they have symptoms, they may have little cough, little flu, little body pains, but they recover the natural way. We recover from flu in 7 days. Now, if you do not recover in 7 days, then the things may be becoming serious, and about 16 to 20% they develop serious illness. Serious illness means they may develop pneumonia, they may develop respiratory insufficiency, they would require hospitalization. And then about in a variable period of time, which depends on the care provided to these patients and his basic underlying condition, approximately 2% will die if we were talking about the healthy people. But there are many things which can come on our way. For example, if somebody is aged, like 75, 80, or somebody has existing cardiovascular disease, somebody has existing obstructive pulmonary disease, somebody has diabetes, especially uncontrolled diabetes, hypertension, and somebody is on immunosuppressive therapy, or somebody is just unlucky, I think he or then some parameters related to the disease itself, somebody during the infection develops hypotension, somebody's oxygen saturation drops, this is very important, oxygen drop, and D-dimers are very high, CRP is very high, LFTs are D-range, RFTs are D-range, there is ARDS or there is consolidation, then the mortality can swell up to like 20% or even more. So we are very lucky that we fall in the category that mortality is relatively less. So I think all these patients, they recover. We do not need many health resources, but this is the population where we need our health resources. Those small percentage of the total population, but since the total population is massive, then we have very, very significant number. And this significant number exceeds our healthcare facilities. For example, this is the maximum number of people we can accommodate in our ICUs and in our high dependency areas. And this is the number of patients. There are two ways to handle this situation. One is to flatten the curve so that at any time, the number of sick patients requiring hospitalization remain below this line. And there is another strategy, and that strategy is to raise the bar. And China did both and succeeded in combating this infection, and the world is also following, and we are also trying to do the same thing. So how to diagnose a case of COVID-19? And the criteria initially, when the pandemic started, were different, and they are now changing. And diagnosis can be made purely on symptoms. As a clinician, my recommendation, my statements would basically recommend, will reflect a clinician's perspective, not an epidemiologist or a public health doctor. So I can diagnose most patients on symptoms, and then circumstantial evidence adds to the diagnosis. Somebody already have one or two people at home suffering from COVID-19. Then, of course, lab tests are required in some cases. Somebody who sits here, who has symptoms, there is circumstantial evidence, there's lab test also. So he is definitely a certain case of COVID-19, but then if you move laterally, then there may be less certain cases. Symptoms may be none. Many of us may have already suffered from COVID-19 without any symptoms. And symptom may be just like ordinary flu, little fever, little body pain, or sometimes pain may be out of proportion, but most have this little flu. And then this is the peculiar symptom. And this is, I think, very, very specific, I would say. About 50% of the patient, they complain of loss of smell and change in the taste. They complain that the taste has become bitter. And this is very, very characteristic symptom. So I think if somebody has flu and weakness and lethargy out of proportion and bitter taste, clinically, I'm already sure. Then if complication occur, there may be productive cough, there may be hemoptysis, there may be dyspnea and shock, and then GIT symptoms are also reported. Occasionally, symptoms related to other symptoms are also possible. Excuse me. Now, confirmation. Well, why we need to confirm the diagnosis? Normally, as a clinician, we want to confirm the diagnosis because treatment is dependent on the diagnosis. That may not apply here, but we still need to confirm the diagnosis for other reason, for I think epidemiological reason. The only definite way to confirm the diagnosis is PCR test, and there are many ways of doing PCR. We can collect samples from different parts of the body, from the pharynx, from the saliva, from other body secretion, but nasopharyngeal swab is perhaps the best because this is the chances where you are likely to get the virus and without getting contaminated. So we call coronavirus RNA reverse transcriptase PCR, and this test is now widely available. Initially, there was a shortage of kits, but now I believe it is available. But all of you must remember that it has got sensitivity of only 70%. That means if you are doing this test on 100 patients who have COVID-19, 30%, that means almost every third person will show the test as negative. So I think this is where your clinical judgment will help you. I will not give even slightest weightage to a negative test if clinically I'm suspecting coronavirus. Then when to do, when to repeat, and what is its exact value, this is based on several factors. I think three things are: number one, physician's perspective. As I've already told you, I am not too keen to have it in all patients. Then patient's perspective, patient always like to confirm the diagnosis. He also want to believe that what he has is not COVID-19. So I have known families, one person had COVID-19 and the entire family had the test, and including the servants. So that is not exactly what I recommend. And then state also, state would dictate the number of kits they have and the facilities they have. So I think based on all these three factors, we decide when to do the test and when to repeat the test. Another way of confirmation is on antibody. Antibodies test, we have the kit and we have the more definite way of testing antibodies like ELISA. And it is positive in 100% of the cases, but only after 15 days. So only when somebody has already recovered or already had ended up in ICU. That is the time when you get the diagnosis through this test. So it has limited value. You can expect that. I think this may help in knowing the exact number of patients in the community. So again, it has epidemiological value more than the clinical value. Having a positive test does not necessarily mean that now you're immune, though we want to believe that. Then if we do PCR and ELISA antibodies, I think sensitivity is close to 99. So if both are in the right direction, PCR is positive, PCR is positive and antibodies are negative, are positive also, then the diagnosis is certain, but this will be in the initial part of the illness, this will be in the later part of the illness. Ancillary labs, because as I told you, this is not simply infection, this affects many other systems and we have to test him the whole body. These are the tests. Whenever patient goes into relatively serious phase, we want to know the CBC. We can expect lymphopenia and leukopenia and thrombocytopenia. CRP may be raised, ferritin may be raised, LDH may be raised, and the level may indicate the level of inflammation. And then we do D-dimers. D-dimers, presence of D-dimer means another component of the disease that there is some coagulopathy also. Then we do, in selected cases, ultrasound is very good, although traditionally we don't use ultrasound for image lungs, but since it is very convenient bedside test and it can pick up lung environment, CXR is very good X-ray test, and HRCT obviously the best test to give you the details of lung environment. Saturation of oxygen with pulse oximetry. This is very, very important. In fact, if I have to identify one out of all these tests, I would say this is very, very important. To let younger people know what is this, I would like to show this picture. Now, this is a graph showing the relationship between arterial oxygen tension, which is what matters, and then saturation measured with pulse oximetry. So normally in a perfectly healthy person, like Professor Rashid Latif Khan, we expect both around 100%. But sometime it may drop in the sickness up to 90%. This is this star, orange star. This is equivalent to 93%. So we ask the patient to keep monitoring their oxygen level. If it is above 93, they are safe. The moment they go below 93, then things become getting serious. Now, many people may not feel this hypoxia. We call them happy hypoxia. So they are hypoxic. Their oxygen may drop to a very, very critical level at 50. They may not be symptomatic, and suddenly they drop because they develop respiratory failure. So that means if there is a sick patient of COVID-19, I think this is what can help. If it is above 93, patient should feel reassured and stay at home. And if it is dropping below 93, he needs oxygenation and perhaps hospitalization. Then ABGs, definitive test of gases, and then procalcitonin. Procalcitonin is actually not a sign of viral infection. If this is positive, that would indicate that there is perhaps some superadded bacterial infection, maybe pneumonia. So that would justify antibiotic. Although we give antibiotic as a medical community in Pakistan, we give antibiotic to everyone, but I think those who have procalcitonin test positive, they need antibiotic. Then to know the idea, the liver function test, kidney function, troponins, interleukin 6, and CTA, VQs, I think when needed. When to say the patient has recovered. Now, the patient has gone through the illness. Now, patient wants to know that he is recovered. There are 3 strategies. Strategies number 1 is based on symptom. If patient has clinically recovered and several days after last symptom, I would be very comfortable telling him that you have recovered. Then the other is time-based. Somebody 12 days after the onset of the symptoms, when he is clinically recovered also, we can say that he is recovered. Of course, if he is having symptom, that means he is not recovered, he is gone into the serious phase. Then is a lab-based, PCR negative and antibody positive is a pakka evidence that patient is clinically recovered. So I think all 3 together would be a definite evidence patient is recovered. And he can rejoin his institution, he can rejoin meeting the family, he can rejoin his family and other things. Now coming to the pathogenesis, why this virus causes so much damage. This is a picture of an alveolus. You know, these are the type 1 cells which are required for gas exchange. These are the alveolus pneumocyte 2 type, which have ACE receptors, and this is the capillary surrounding the alveolus with our normal blood cells. So coronavirus, this is normally, this ACE2 actually converts angiotensin 2 into angiotensin 1-7. This is a derivative of angiotensin 2 which has vasodilator action. In other words, this is one way of inactivating angiotensin 2 into a vasodilator substance. Okay. Now, once coronavirus comes in, it attaches to pneumocytes, ACE receptors, and then it starts destroying these cells. So angiotensin 2 then takes the wrong direction. ACE2 doesn't work. Angiotensin 2 takes the wrong direction. It causes vasoconstriction in the local area. It also leads to production of reactive oxygen species that it may cause endotheliitis. This is a new term we learned, and this may cause involvement of endothelial cells of the capillaries, and the endothelial cells basically shrink in their size, making the capillaries more porous, and then that also activates von Willebrand factor, which is also present in the cell wall, that may lead to thrombosis. Now, this picture is basically to show that this is not just the receptor issue, this is much more. There is hemodynamic involvement, there is involvement of vessel, there is involvement of clotting factor, and that is why some people, they become very, very sick. Now, let's see what is happening inside pneumocytes. This is the pneumocytes. So once the virus enters into the cells, it uses our cells manufacturing facility to manufacture its own RNA and its own proteins, using what is called RNA-dependent RNA polymerase and proteases inhibitors. And then ultimately they are reassembled and many viruses are produced and they are shed and they come back to the alveolus and they induce intense inflammation and they also coughed up to affect other people. Now this is the inflammatory cells coming into the alveolus. So the alveolus will be like what we call consolidated, and there will be interstitial edema also. This will spread to the neighboring alveoli, and ultimately pneumonia will develop. Now, this is what is happening in the alveolus. There is infiltration of macrophages. Macrophages takes up the antigen, present them to T cell then to interleukins, TNF alpha, interleukin 1, interleukin 6, then it directs lymphocyte, B lymphocytes to produce certain antibodies, and then there is further process going to this is the hyaline membrane formation if things become chronic, fibroblast, and then capillaries involvement and thrombosis formation and cytokine storm. All the things come into play, and वो जो सुनते थे बचपन में कि घुमसान का रन पड़ गया, तो everything comes into play and things become very, very complicated. Now I am coming to toward the end of my presentation. Actual stuff is very, very crazy, and I don't want to go to the crazy details. I have made it very simple for two reasons. One reason is that my audience does not need to know those crazy details. And second reason, perhaps the bigger reason, is that I myself do not know those details. So let's, I think, accept the simplest version. This is the coronavirus. It obviously primarily is infection. It affects lungs and it causes viremia. On the basis of these two, patient will develop fever and myalgia and other flu symptoms, and this will translate into therapies like symptomatic treatment and antiviral treatment and convalescent plasma. My colleague will talk more about this also. And second component is that it may cause ARDS due to cytokines and pneumonia through the inflammation. And this may result in dyspnea and critical hypoxemia. This will translate into certain therapies like oxygen therapy, ventilator, and ECMO. So I think this is what we can prevent by timely pulse oximetry. And then there is cytokine storm. This inflammation initially plays a very good role and saves many of us, but sometimes it goes out of control and then it becomes damaging. Cytokine storm can cause local and systemic damage. It can cause tissue necrosis in the lungs, but as you know, it can cause systemic necrosis also, and patient may develop shock. And this might lead to the usage of vasopressor and interleukin 6 antagonist tocilizumab or dexamethasone, which is now become very popular in sick patients. And then there is coagulopathy. This is what is perhaps the most serious component, and disseminated intravascular coagulation. And this results into myocardial infarction, pulmonary infarction, strokes, and it translates into the treatment with the novel oral anticoagulant drugs, low molecular weight heparin, and antiplatelets. So this is all what's going on in the lungs and the body. But as you know, the ACE receptors are present not only in the lungs but in the body. Ultimately, this disease goes beyond lungs and can affect multiple organs through the virus itself and through the complication through these pathological mechanisms. And there is involvement of the multiple organs, and then ultimately can unfortunately lead to death. But we must remember this happens in a small percentage. In our country, that number is very small, like 2%. And we must feel good that majority of us, even if get infection, will recover. And many of us may actually have already recovered from the infections. I hope this was simple enough for all to understand. So I made it simple because I believe simplicity is in my genes. Thank you very much. Over to Dr. Asma.
Thank you so much, sir. It's, as usual, always a brilliant presentation with excellent slides. Now, our next speaker is our guest speaker, Dr. Somia Iqtidar, who's an associate professor at King Edward Medical University. She's a general secretary of Pakistan Society of Internal Medicine and a member of Corona Expert Advisory Group. So she's going to talk on treatment of sick patients of COVID-19. Over to you, Dr. Somia.
I was saying कि प्रोफेसर अजीजुर रहमान के बाद प्रेजेंटेशन देना दुनिया का सबसे मुश्किल काम है, बिकॉज ही इज सो गुड एंड इतनी मेहनत उन्होंने प्रेजेंटेशन पे की होती है कि आप जितनी भी अच्छी प्रेजेंटेशन दे रहे हैं आप ही के बढ़ जाते हैं. सो सर, as usual, an excellent presentation. It's just I have to this. So, sir, I will be talking about, okay. So, we always thought that the biggest threat to human race is this nuclear explosion. So, this was the idea in our mind from the times the nuclear bombs came into existence. But now we know that the biggest threat to human race are not nuclear explosions, but microbes. And the biggest threat which can lead to human catastrophe are actually not missiles, but microbes. And if anything kills over 10 million people in the next few decades, it's likely to be a highly infectious virus rather than a war. And the impact of viruses has been huge in the past years as well. And we know that we had influenza in 1918, which caused 100 million deaths. And then it repeatedly came in the subsequent years and lost many precious lives. Then came the era of coronaviruses. And we had in 2002 SARS, and then 2012 Middle East Respiratory Syndrome. But once in a century pandemic occurred in 2019 and led to coronavirus infectious disease, which is known as COVID-19. And we have lost about 0.5 million people because of this pandemic going on. So as introduced to you, my name is Dr. Soumya, and I will be talking to you about the management of sick patients of COVID-19. So before I tell you which are the sick patients, let's categorize them into three definitions, like suspected cases, probable cases, and confirmed cases. And let's see how we label them. A suspected case of a virus infection of corona is the one who has a short febrile illness, that is fever, sore throat, cough which can be new onset or worsening of existing, shortness of breath, new onset or worsening of existing, and flu-like illness, body tiredness, aches, fatigue. And there are two new symptoms that we have come across which are very peculiar and associated with this disease, which are loss of sense of taste or smell. And some patients, they also present with gastrointestinal symptoms like abdominal pain and diarrhea. So if any two of the following symptoms are present, then you suspect that this is a coronavirus patient. And as told by Dr. Azizur Rahman, if you have an evidence that he has a close contact with a confirmed or a probable case, as like he has a patient in the family, or he has traveled to an area or a local community in which he's living, has active cases going on, then this makes the diagnosis even more definitive. Now, when do you call that patient is a probable case of infection of COVID-19? A suspect case for which testing either is inconclusive or was not done for any reason, or if the patient has a high degree of clinical suspicion and radiological findings which are suggestive of COVID pneumonia, but the lab results do not support it, then these patients are labeled as probable cases. And a confirmed case is the one who has a lab confirmation of COVID-19 and irrespective of clinical signs and symptoms, thereby meaning that they can even be asymptomatic. So when we classify this disease, we label them as either asymptomatic infection, mild disease, moderate, severe, or critical disease. So the spectrum is very wide, with no clinical symptoms at all to very severe and critical forms. So asymptomatic patients are those patients who are tested positive for SARS-CoV-2 infection by PCR, but they do not exhibit any symptoms. Mild disease are the patients who present with symptoms which are suggestive of COVID-19, as I told you in the suspected definition, but they are vitally stable and there are minimal X-ray findings, and oxygen saturation is more than 93% at room air. So the main criteria I would say where you classify this disease as mild, moderate, and severe would be oxygen saturation and hemodynamic stability. Moderate patients are those who have symptoms of COVID-19, which are suggestive of this COVID-19, and they have hypoxia. And as mentioned earlier, this can be a silent hypoxia or happy hypoxia in which patients do not feel short of breath. But when you check their oxygen saturation, it is between 90 to 93% at room air. Their chest x-rays may show infiltrate, but it usually involves less than 50% of the lung fields, and there are no complications and manifestations related to severe condition. While when the patients become more ill and severe, then they have clinical features suggestive of pneumonia, and they have any of the following. Either their respiratory rate is very high, that is more than 30 beats per minute, 30 respiratory breaths per minute. Their saturation of oxygen drops and it is less than 90% at room air, and the chest x-ray has infiltrates which involves more than 50% of the lung fields. Now coming on to the most severe form, which is the critical form of coronavirus disease, and any of the three manifestations like ARDS, multi-organ dysfunction, or septic shock. If they are present in any patient, we label them as critical. ARDS, you all know, is present in the form of bilateral ground glass shadows in the chest x-ray with severe drop in the saturation, and patient has full-blown respiratory failure. It can involve all the systems like your kidneys, your gastrointestinal system, your heart, and the multi-organ failure ensues, then this is also a sign that patient is going into a critical state. Or if the patient develops superadded bacterial infection and sepsis and results in septic shock, which is manifested by mean arterial pressure of less than 65 or a serum lactate of more than 2, then we also label this patient as a critical case of COVID infection. Now, where to admit these patients and how to treat them? The criteria for admission basically depends upon this classification, that whether the patient is asymptomatic, mild, moderate, severe, or critical. If the patient is asymptomatic or he is suffering from mild disease, as I told you earlier, that is, there is mild fever, cough, and there is no shortness of breath, and the saturation is more than 93% at room air, and patient is hemodynamically stable, he can be managed either in an isolation facility, which can be a government setup, or a home isolation, provided he fulfills the criteria of qualifying for home isolation, where he has a separate room and a washroom where he can isolate himself. If patients have moderate disease, that is their oxygen saturation is between 90 to 93%, they need to be hospitalized in an isolation ward which has monitoring facility and oxygen supplementation is required. If patients develop severe disease, their facility needs to be stepped up and they are shifted to high dependency units, and the critical disease patients have to be managed with mechanical ventilation in ICUs. Coming on to the treatment of the sick patient. So before we start treatment, let's talk about, this was the talk of the town, that prophylaxis of COVID-19. And I know that many physicians still believe that there is role of some drugs in preventing this disease as well. But the medical literature so far reported has shown that there is no role of prophylactic chloroquine or hydroxychloroquine or any other drug at this time. When I say at this time, we may be able to have them in future. Coming on to the management, since it is a viral disease and we know that most of the viral disease, we do not have any specific antiviral against them. So to date, there is no specific treatment for COVID-19 infection either. And this includes chloroquine, hydroxychloroquine, ivermectin, famotidine, montelukast, colchicine, and many other drugs which are being used by the physicians for treating COVID-19, but they are not the specific or a definitive treatment for COVID-19. They are all under trial and some of them only have a supportive role. When the patient is having mild disease, then you do not need much and you have to provide only supportive care to the patients, which includes that if patient is having fever, you can give him acetaminophen or Panadol. If he has sometimes diarrhea, you can rehydrate the patient. Oral hydration is preferred. If there is cough or sore throat, you can prescribe antihistamines to these patients. But the moderate, severe, and critical disease patients need specialized management in a hospital setting. Apart from the supportive therapy, all these patients must be assessed for the cytokine release syndrome. Very adequately explained by Professor Azizur Rahman what cytokine release syndrome is, where there's inflammation and release of cytokines like TNF, IL-1, IL-6, and these cytokines then damage your alveolar lining and they cause multi-organ dysfunction as well as there is pneumonia and ARDS-like picture in the lungs. So the presentation is that the patient presents with, because there is release of anti-inflammatory and inflammatory mediators like TNF, and they lead to fever. So patient presents with fever, which is usually more than 100 degrees Fahrenheit. Patients develop hypoxia and dyspnea. And when you get an X-ray chest or a CT chest of these patients, it shows infiltrates, which when compared with the previous X-rays are increasing in size. The investigations that you need to do at this time are the serum ferritin, C-reactive protein, LDH, D-dimers, which give you a high value indicating that the patient is going into a cytokine storm. In other patients, you have this baseline investigations already shared with you, which is CBC, liver function, urine function, electrolytes, in some cases blood cultures, ECG is required, and optional investigations in few cases where you have a suspicion of bacterial infection, procalcitonin levels are done. If there is involvement of heart or myocarditis, which is usually seen in viral infections, you can go for troponin or echocardiography or pro-BNP. In cytokine syndromes, you can check the levels of IL-6, which is one of the inflammatory markers against which we use drugs as well, and HRCT scan test if you have the facility available. So coming on to the treatment of the cytokine release syndrome. First of all, the mainstay of treatment for any pneumonia, we all know, which comes with hypoxia, is oxygen, and oxygen is the life-saving treatment. And oxygen therapy can be delivered in an escalating manner depending upon the hypoxia and the saturation of the patient. And it can be delivered by a nasal cannula, face mask, or a non-rebreather mask. And good results have been shown with high flow nasal cannula, and it should be given a preference where available. Awake proning should be encouraged in cooperative patients in which the patients lie in prone position for 12 hours, and it helps in improving the saturation and ventilation of the lungs. Steroids, which were labeled as the breakthrough drug in COVID-19, looking at the recovery trial, which was conducted in more than 150 hospitals in UK, it showed that low-dose dexamethasone, which is 6 milligrams per day, when given to patients who require either supplemental oxygen or mechanical ventilation, they showed improvement and there was decreased mortality reported among them. So on the basis of this recovery trial, it further added benefit of adding steroids to these patients. We previously used steroids only in septic shock patients because we knew that steroids can delay the viral clearance. But given this new data that we have got from recovery trial, now the steroids are given in moderate to severe disease in patients who are requiring oxygen or who have a CRP level of more than 70 and it is rising in the last 24 hours in the absence of bacterial infection. You can give dexamethasone, methylprednisolone, or even oral prednisolone. And the criteria is based you look at the improvement of oxygen saturation or normalization of CRP to determine for how many days you need to continue with the steroids. Then, as I told you in the beginning that there were no specific antiviral drugs, but recently 2 antiviral drugs have shown encouraging results and they have been given emergency approval for use in COVID-19. One is the remdesivir, which is an injectable antiviral, and the other one is favipiravir. It was used in Japan with the name of Avigan in influenza. But now some of the countries like Russia and Germany, they have given approval for using it in COVID pneumonia. And it is given both in moderate, severe, and critical disease. As it is a viral disease, so obviously there is no role of antibiotics and routine use of antibiotics is not recommended, but they should be used only in cases when a bacterial infection is suspected, which can be seen with the rise in the procalcitonin level or a rise in TLC in the absence of steroids. And there is no role of prophylactic antibiotics, including azithromycin, to prevent a secondary infection in COVID-19. Then comes the role of vitamin C, vitamin D, zinc, and calcium. So many physicians have been giving these to boost immunity, but it's my personal opinion that anything which boosts your immunity is your diet, your lifestyle, and your state of mind. So if you are having a balanced diet, which is balanced in all the components of the food, carbohydrates, proteins, minerals, and you have sufficient quantity of rest and sleep, and you have active lifestyle, this is the best immunity that can be offered to you. The role of Sena Makki, the role of Kalwanji, and the role of garlic, because it has been talked by many people over the social media. You've been getting questions as well, but there is no definitive proven role of these herbal things in the management of COVID-19. And although we know that there can be some beneficial effects, but we know that Sena Makki is a laxative, and patients with coronavirus disease present to you with diarrhea, and they can present with severe dehydration if they are consuming this. Similar is the case with garlic. We do know that garlic had some antimicrobial properties, but no role has been established in COVID-19 yet. So this is all from my side. The discharge criteria, I also wanted to tell you. The discharge criteria for these patients.
Sorry, meanwhile, let me compliment Dr. Somia for giving a very, very crisp message. She has told us exactly what works and what doesn't work. So I think that was the main reason why we had this seminar. We should know, because there is a lot of things which are being claimed as they're helpful, but they don't actually work.
Tania, I think she has left the meeting. She's going to re-enter.
Okay, all right. She said she was about to do at the end of the presentation. Maybe we can now call next.
Okay. So we'll continue with next presentation. For this, I would like to invite our next guest speaker, Professor Saqib Saeed, who's a renowned pulmonologist, and he's heading the Institute of Tuberculosis and Lung Diseases at King Edward Medical University. He's going to talk about the treatment of critically ill patients. So, Professor Saqib Saeed.
Thank you very much, Professor Azizur Rahman. Thank you, Asma, for the invitation. It's indeed a pleasure to be talking to such an august gathering. And my mentor, Professor Rashid Latif, who inspired me to become a gynecologist at one time, but it never materialized. I ended up being a pulmonologist, really. But the inspiration is still there. If I am reborn, I will perhaps be a gynecologist and try to slide into the boots of Professor Rashid Latif Khan.
I think there's some problem occurring with the internet of Professor Saqib. So I will have our presentation from Professor Tahir Masood first, and then we can have Professor Saqib Saeed afterwards. So Professor Tahir Masood, principal of our Rashid Latif Medical College, who is going to talk on COVID-19 in children.
Thank you very much, Dr. Asma Qazi. I'll share my slide. Okay, first of all, I would thank the presence of especially Professor Rashid Latif Khan and Professor Farooq Zaman, and I would also extend my appreciation and gratitude to the guest speakers, Professor Somi Iqtidar and Professor Saqib Saeed, for their presence here, and thanks to Professor Azizur Rahman for arranging this webinar on obviously very important and current burning topic of COVID-19. Now, majority of the aspects these have been covered regarding the overall spectrum of the disease, and the pathogenesis and the treatment was discussed by Dr. Somi Iqtidar. I would concentrate primarily on the COVID-19 in children, especially in reference to the differences in children compared to adults. The overall the picture is the same, but there are certain salient points where the children are different from adults. Now, my presentation would encompass, first of all, the burden of disease in children, because as it's clear with the literature, with the data worldwide, the children are less likely to be affected compared to the adults. Then second important question is how easily children catch the disease. That is the attack rate, because the attack rate of children is not the same as this is present in adults, and supposedly children catch disease less compared to adults. The third is that this is important, that whether the children, they are infectious to other contexts in the same way as the adults are. And then finally, certain clinical features which are peculiar to children and also the outcome in children. Now, first of all, the burden of disease among children. In fact, if we see the world literature, actually, various geographical locations, they give different data regarding the number of affected, percentage of children who are affected, and children overall account for up to 5% of confirmed cases. And the studies from China, US, UK, Italy, and Spain, they give different figures varying from 2% in China, where the median age is around 7 years. In US, median age is 9 to 9.6 years. And in UK, the incidence is less than 5%. In Italy, this is 1.2%. Median age is relatively less. And in Spain, overall percentage of children who are affected is 0.8%, with less median age compared to the other studies. Now, it's in fact, these statistics are based on the hospital data. It's not actually, though, this would not represent the overall data, because these are the patients who would come to the hospital or who would actually present to the healthcare facilities, and they would undergo testing. There hasn't been a widespread serosurveillance. Only widespread serosurveillance can tell us that what is the spectrum of the disease, because as we understand, many of the patients would be asymptomatic. So true burden of disease cannot be assessed by this data, which is primarily data based on the PCR testing or on the symptomatic patients or patients who would present to the healthcare facilities. Now, I would just share with you these various figures from now. This is the data from the US regarding. So just to mention again that these are the percentage of children who are affected. Number of out of the total number of cases, children constitute about less than 5% of total confirmed cases with COVID. And this is actually the data from US regarding the cases, confirmed cases per 1 million US population, and as it shows that the majority of the cases are in the after 50 years of age, and children constitute and children rate is about 1.5 per million population. So that would mean that children are less affected, or children, the total, they would constitute less percentage of affected patients. This is actually the mortality, and these are the figures from the Wuhan, where the epidemic started. Out of 72,314 patients, which were total detected, as you would see here, that the mortality in children, that too was not there under 10 years of age, and this is 0.2% compared to the mortality in individuals beyond 50 or 60 years of age. So this is the data from Pakistan, and this is by the National National Control and Coordination Center. As you see here, that in Pakistan we are getting cases from 0 to 9 years and from 10 to 19 years of age. And though this is the data of mid-June, we cannot really come up with the exact figures at this moment, but children are fairly affected, and according to this data, the percentage of children who have been affected or who have been confirmed positive with COVID, they constitute around 7% of total cases in Pakistan. This is again the data from Pakistan, which shows that as regards the confirmed cases by age and gender, male are affected more compared to the females. And again here, as you would see here, about 76% of confirmed cases are below 50 years of age. Whereas if we see the mortality, 74% of the deaths which are occurring because of COVID, these are beyond, in individual beyond 51 years of age. Mortality in children is very less, or mortality in younger age is less compared to the mortality in grown-up adults. No, in fact, coming on to this question, that what is the attack rate? How much transmission is present in children? Though it's just difficult to say for, if the widespread zero surveillance studies are not there. And here, 5 studies are quoted from different parts of especially from China, from Japan, and from the other cities of China. Apart from one study, which was from Shenzhen, that indicates almost equal attack rate in children and adults, but the other 4 studies, they clearly indicate that attack rate in children, that is less. That would mean that if children are exposed to contacts, they are less likely to contract the disease compared to their counterparts in adults. So that would mean the children are less likely to be affected if they are exposed to the contacts. Then the question is then how infectious the child is once the child gets that, because that is important. If children are less likely to be affected, but they can spread the disease to adults in the same household. Now again, this is difficult to assess because the number of index cases in children, that these have been less, and this is because of the fact that schools were closed earlier at the start of the epidemic, and so children, they don't move out frequently. It's so they're less likely to be index cases. So at the moment, it's though it's known that in a household, children are less likely to be source of infection, but that is because of the reason that children, they don't move out and the schools are still closed. So in fact, it's difficult to say, but it does indicate from multiple family clusters that children are less likely to be the index case. Coming on to the presentation in children, now since this COVID-19 is a new disease, and this has emerged and is still an evolving disease, and many of the characteristics of the disease that have come into picture only after some time. And in fact, the things which are considered things which were considered true in the past, they are no more valid these days. And the pathogenesis, the spectrum of the disease, that the knowledge of disease that has changed. And in fact, one can say that COVID still is a baffling disease, and just like blind men discovering the characteristics of an elephant, so everyone would have different perception based on the problem, based on the feel which they would have of the elephant. So it's just like the same. Still, the disease is evolving, and as the symptomatology would emerge, as the treatment modalities and pathogenesis would emerge, obviously the treatment is likely to change as this has emerged. That in the past, drugs like chloroquine, hydroxychloroquine, ivermectin, and antibiotics were considered, but nowadays no such drugs are considered to be effective or beneficial in patients with COVID. Clinical course and complication in children. In children, the majority of the children, compared to the adults, they are asymptomatic. Though again, it's difficult to say at the moment because we are not actually doing the widespread testing. Only widespreading would give us the figure that how many children are asymptomatic. But according to the various studies, starting from China to Italy, the figures have been variable from 4 to 32%. In Italy, where widespread population was studied, it was shown that the percentage of asymptomatic children that constituted almost more than 25%. Now, in symptomatic, though the overall clinical picture is the same, as regard the clinical manifestations are concerned, majority of the clinical manifestations, they are same as this was discussed regarding the probable case, the case definition of COVID. But in children, we know that they have relatively milder disease. And though fever and cough would be present in more than 50% of symptomatic patients, rhinorrhea and sore throat is present in 30 to 40% of patients. This is actually the symptom, the various type of symptomatology which have been seen in these children. Diarrhea and vomiting is considered to be more common compared to adults, and they can solely present with diarrhea and vomiting. About 10% of cases would have diarrhea as the sole complaint. In the past 1 month or so, there have been cases where the rashes, which are resembling chilblains, these have been noted to be present more on the feet and toes. Various other symptomatologies have emerged. I will come to that, which is regarding the hyperinflammation syndrome. Now, larger study of the pediatric patients that has come from China, and according to that, the severity of disease in children that ranges from mild cases, which is about 51% of cases, and they would have only fever, cough, and maybe a little bit fatigue. Moderate would be around 40%, where there can be pneumonia with clear-cut symptoms, or there can be subclinical cases where the chest imaging would be positive. Severe cases are around 5%, and they would present with dyspnea and central cyanosis and hypoxia and other clinical features, and some of them would present with cytokine storm. Critical patients constitute only about 0.6% of total cases, and they would present with acute respiratory distress syndrome. They can present with shock, and there can be multi-organ dysfunction as well, where more than one system would be involved. Now, I want to specifically highlight one specific entity, which is the multi-system inflammatory syndrome in children, which was initially reported in April in UK, and this was a cluster of 8 patients who presented with cardiovascular shock. They presented fever and hyperinflammation, and in fact, these children had certain manifestations which were similar to the disease, which is a vasculitis involving primarily the coronary arteries. That was Kawasaki disease. So similar picture like Kawasaki disease that was noted initially in UK, and some of these children, they presented with even toxic shock syndrome or serious manifestations which are very deadly. That is hemophagocytic lymphohistiocytosis or macrophage activation syndrome. Some of these children presented with these features. So overall, these children were grouped under the category of multi-system inflammatory syndrome, and some of these cases were reported later on from US, and then WHO and CDC came up with this term of multi-system inflammatory syndrome in children, which would encompass not only children who would be mimicking Kawasaki disease, but children with other manifestations where the other systems would also be involved. This actually occurs not during the attack of COVID infection. This would occur about 2 to 4 weeks after infection, and by that time, obviously, most of the children would not show up with positive PCR, though the antibodies against the SARS-CoV-2 virus would be detectable in the patient, and but this type of syndrome, multiple inflammatory syndrome, is unlike Kawasaki disease, because Kawasaki disease affects relatively younger children, and the extent of coronary involvement is not that much as this was noted in UK in these kind of patients. So these are the patients who were mostly beyond 5 years of age, and the cardiovascular involvement was more frequent and more severe. Then this case definition was reached at, and this case definition is based on 6 basic criteria. One is that the patients are under 21 years of age, and there should be fever, either recorded fever beyond 38 degrees centigrade, or there is subjective fever, subjective complaint of fever for at least 24 hours. Then laboratory evidence of inflammation that is there, and that is what has already been described by Professor Azizur Rahman and by Professor Somi Iqtidar, and this is all those acute phase reactants, CRP, ESR, fibrinogen, procalcitonin, D-dimer, LDH, various interleukins, and with reduced lymphocytes, and this was also associated with low albumin. So all these markers, these were present, and The fourth criterion is that there should be at least more than 2 organ involvement. And then there should be a relationship, there should be a correlation, because this is related with COVID-19. So the COVID-19 either infection should be detectable. PCR was present in a certain number of children, very few children, but antibodies were present. But even the COVID exposure within 4 weeks prior to onset of symptoms, with these, obviously, with this presentation would put the patient into this category of multi-inflammatory syndrome. And then lastly, with this clinical picture, if no other plausible diagnosis, no other possible diagnosis can be made in this epidemic, one should consider that patient is suffering from this kind of syndrome, hyperinflammatory syndrome. Now, the laboratory findings have been discussed by Professor Azizur Rahman, but I would primarily concentrate here that where children seem to be different from adults. Now, lymphocytopenia is considered, especially in moderate or severe cases, lymphocytopenia is considered to be one of the important features in adults with obviously more polymorphonuclear leukocytosis. This is relatively less commonly seen in children, especially in mild to moderate cases. And this is because of the fact that children have generally the preponderance of lymphocytes, normally have preponderance. So the lymphocytes counts, they are normal or they can be even raised. CRP and procalcitonin, procalcitonin obviously, as this has been rightly highlighted, this would indicate superadded bacterial infection, but these are milder raised compared to adults. More rise would be seen in adults. Liver transaminases is transient elevation and marginal elevation of transaminases is very commonly seen in children. Coming on to the radiological findings. Now, this is again somewhat different from adults. Abnormalities are less rare compared to adults, though in children there hasn't been any consensus regarding the typical radiological findings in children, because you are well familiar that children, acute respiratory infections are very rampant in children. So the children who present with pneumonia, with the respiratory infections because of conditions other than COVID. So one needs to differentiate COVID from other infections, from other both viral and bacterial infections. But these were possibly 3 different findings which have been mentioned about by the American College of Radiology, that there are bilaterally distributed peripheral and or subpleural ground glass opacities, and or there may be consolidation, and there can be non-specific findings which can be unilateral perihilar or central ground glass opacities. Now here it's worth mentioning that these opacities, in contrast to adults, are more centered rather than more distributed peripherally. Or there can be consolidation or bilateral peribronchial thickening or peribronchial opacities. These are the typical X-rays, these are the X-rays from the COVID patients who were admitted in the intensive care unit of the Children's Hospital. As you would see here, that there are opacities on the X-ray on your left, bilateral widespread opacities with consolidation, bilateral consolidation, which is seen on the X-ray on the right. CT scan test, as you all know that now this is considered in some cases where you are not getting the PCR positive and the patient is symptomatic, though CT scan is considered to be, CT scan test is considered to be more sensitive rather than having the COVID PCR testing, because that would indicate typical clinical findings. CT features in children are also mild compared to adults, and these are again bilateral ground glass opacities, which are more in the central region rather than in the peripheries. And CT changes, just like adults, may be found also in asymptomatic children. CT test is indicated in American College of Radiology would recommend that CT scans should only be done in children who are hospitalized and who are critical. Otherwise, routine CT scan should not be performed. One important question, especially when it comes to especially the involvement of the obstetric colleagues, that is concerned, because obviously the pregnant women and women with the childbearing age, they would they're likely to have COVID. So there is a question of perinatal transmission. Now, there is no evidence of vertical transmission. So this virus, vertical transmission has not been found. That is the transplacental passage of the virus and presenting in the newborn with various manifestations. This has not been reported. Neonatal infection can occur. Obviously, if the mother is infected, then the neonate can be infected. But the rate infection is not considered with vaginal delivery, or breastfeeding is always advised. We always advise that if even the mother with COVID, she should continue breastfeeding. She obviously should take precautions, but breastfeeding should be continued. And there is no evidence that the virus would be transmitted through the breastfeeding. In fact, there can be isolation of the virus, particle to the virus in the breast milk, but that is not infective. And the contact with the mother is always allowed, and mother needs to take the precautions. Now, treatment, I would not dwell on that, and in children this is primarily sportive, and the focus should be on prevention and management of complications, and that is just like an adult's specific treatment would depend upon the clinical situation, that if the child has multi-system inflammatory syndrome, then and he's suspected to have cardiac involvement as well. So timely intervention in the form of IV immunoglobulins, high dose aspirin, and steroids that would save these patients. And in fact, if the patient goes on to get macrophage activation syndrome and hemophagocytic lymphohistiocytosis, that is very, very difficult to treat, and that carries a very high mortality. But early diagnosis and early intervention, that would be important. Now, it's worth here to mention that at the present moment in Children's Hospital, there are 4 patients with this multi-system inflammatory syndrome who are admitted, and 1 of them expired because of the cardiac involvement. Antiviral, as this has been mentioned, especially in the recovery trial, and immunomodular therapy, that has to be decided on a case-to-case basis whether anti-interleukin to be used or not. So thank you very much. I would stop here, and later on, if there are any questions, I would be pleased to answer those. These are the references.
Thank you so much, sir. It was a wonderful presentation, and lots of questions on kids' COVIDs have been answered. Now we will move on to our next presentation, which is by Professor Abul Fazl Khan. He's going to talk on operating on COVID-19 patients.
Thank you very much for allowing me to share my thoughts and experience on operating on COVID-19 patients. I'm going to talk about operating on COVID-19 patients. Now, as this disease is new for physicians, so it is new for surgeons as well. And we were as much scared about it as anybody else. We only knew that surgeon and anesthetist are more at danger than other treating physicians. Now, we are all aware of impact of corona on surgical patients. Recent studies have shown that surgery may accelerate and exacerbate disease progression of COVID-19. Patients' immune function is a major determinant of disease severity and containment, and population with low immune function, such as elder patients, surgical patients, are more vulnerable and have higher mortality after COVID-19 infection. Surgery may not only cause immediate impairment of immune function, but also induce early systemic inflammatory response. Initially, all surgical services were suspended, but we realized that we have to continue with obstetric service, we have to continue with trauma and acute care, including vascular intervention. We had to intervene in cancers which were presenting with intestinal obstruction or airway obstruction, and non-cancer conditions like acute abdomen. And many unnecessary lives were lost because surgeons were afraid to treat these patients. Restarting surgery in corona patients is now our priority. The roadmap to surgical resumption should be progressive and cautious. Educating doctors, patient and family for the need of pre-isolation, screening and post-operative isolation of patient is of utmost importance. Better protection of healthcare workers from COVID-19 will restore their confidence and will enable them to provide services to these needy patients. Those who are non-COVID, they are afraid to come to COVID hospitals. In UK, they have created green facilities, they have taken over private clinics, and they have started non-COVID facilities with special protocols in those hospitals. Now, the surgery can be classified as an emergency surgery where it is essential to operate within 24 hours to save life, or urgent when this period can be extended to 72 hours. When the surgery can be deferred to 4 weeks, we call it as level 2, level 3 when up to 3 months, and level 4 more than 3 months. So if somebody is COVID positive and this surgery can be deferred for 4 weeks or 3 months or longer, we let the patient recover from corona and then operate. But if he has an emergency situation or an urgent condition, we have to operate while they are still infected with the virus. And these life-threatening conditions can be intestinal obstruction, vascular obstruction, bleeding, localized infection, abscess leading to septicemia, or compression of spinal cord, which can lead to permanent paralysis. The emerging data guide us about post-operative risk. When major surgery is carried out in COVID-positive patients, whether diagnosed perioperatively or post-operatively, the risk appears to be substantial, and we must ensure that we keep this risk as low level as possible. Morbidity secondary to surgery as well as COVID symptom is much higher. There are cancer patients who can be corona positive as well. And in many of these patients, if we can go for new adjuvant therapy, or those who are already on chemotherapy, to extend their new adjuvant chemotherapy and delay their surgery. But when it is absolutely essential, we have to intervene. We have to improvise care of urgent non-cancer surgery. For example, if patient had stone in CBD, we used to operate early, but now we send these patients for CBD stenting. Similarly, if patient has a condition in which operation is necessary, but can be done under regional anesthesia, we avoid general anesthesia, which predisposes the healthcare workers to increased risk of infection. Peri-procedural isolation is of utmost importance to protect the patient as well as healthcare workers. Now, it is essential that we set up services for COVID patients. We have to improve our operating infrastructures. Our operation theaters were designed to have positive pressure ventilation. In these, we need negative pressure ventilation. Dedicated operation theater complexes and indoor services for corona positive patients. You cannot mix corona positive with non-positive patients. We need negative pressure ventilation. Controlled entry and exit is of utmost importance to protect those who are working there. Proper system of waste disposal is also essential, as it was before, but it has become more acute. Now, availability of PPE level 3 and 4 is altogether different from common surgical masks. And we need to train healthcare workers how to use these effectively. We have to have a person who conducts the fit test. It's not just important to wear a mask, it's to wear it effectively. A lot of doctors died in UK because they were not using masks properly, or they were not doffing or taking off their protective gear effectively, and they got themselves infected while they were removing the mask and the gown. Anesthesia department has been depleted because of a number of infections. We need to rehabilitate and restore strength of anesthesia department. And those who are working there need to be trained in rapid sequence intubation so as to minimize the aerosol generation time which occurs at the time of intubation. With so much leftover cases, we need to screen and prioritize which patient needs surgery first and which can be asked to wait for a little while. Organization of operation room flow is very important. Unnecessary personnel should not be allowed in, and there should not be an unnecessary traffic. We need new protocols. With masks, it is difficult to communicate. We need to develop different ways of communicating with the team. We should discourage a lot of talking within the operation theater, which generates a lot of aerosol. Ambulation. Now, those patients who are COVID positive, when they need to be moved through a non-COVID area, we need to have special trolleys with cover and with HEPA filters attached, so that while they are being transferred for ultrasound or X-ray or other facilities which are shared with non-COVID patients, they do not cause infection to others. The lifts are a very important source of disseminating infection, and every effort should be made to prevent infection there. These operation theaters should be geographically segregated. OR supplies, personal protective equipment should be designated for COVID-19 care and delivered there. We need to assign a dedicated infection control person who is trained to supervise appropriate donning and doffing of PPE for operating room personnel who will be in the room for the COVID-19 patient. We need to assign area for containment and disposal of attire. We need to clearly display the plan and map for personal reference. Now, while we take care of the COVID patients, we need to create green facilities for non-COVID patients and dedicated healthcare institutions where there are no COVID patients, where all healthcare workers are tested twice a week to be PCR negative. These patients are isolated 14 days pre-operatively and 14 days post-operatively. They have one screening PCR 15 days before surgery and 24 hours before surgery. Surgical team is isolated 2 days before surgery. They don't go to a COVID area. They stay at home and they isolate themselves. And 24 hours before surgery, they get their PCR done so that they are not causing infection to non-COVID patients. So just to draw conclusions, already inadequate healthcare services in Pakistan have been further compromised and challenged. Patient turn-up and confidence has declined sharply because of fear, because of lockdown, because of difficulty in movement, and because of loss of earning. We should develop separate COVID and non-COVID facilities to reduce fear of the patient and healthcare workers. Surgical services should be reinstated with proper pathways and with a lot of deliberation and a lot of rehearsals, and care and ensuring safety of patients and healthcare workers is of utmost importance. So I'll be very glad to answer any question. I've just briefly outlined the pathway for restoration of surgery for COVID patients. So if there are any questions, I'll be very willing to answer.
Thank you so much, sir. We'll have the question and answer section at the end of our presentations. So we will come to our final presenter, Professor Saqib Saeed, pulmonologist who is working at Harvard Medical University and leading the Department of Tuberculosis and Lung Diseases at King Medical University over there. So he's going to present to us, talk about treatment of critically ill patients. So over to you, Professor Saqib.
Thank you very much. I hope I'm able to overcome the ditch in the earlier presentation.
Yes.
I hope my presentation is visible now.
Not yet, sir.
Is it visible, please?
It is visible. Congratulations.
Yes, sir. Thank you very much. Starting my presentation will basically slightly overlap with Soumya's presentation, since severe and critical disease is very akin to each other, really. So I will just touch on the serious disease and then the critical disease and then the modalities that can be used to treat critically ill patient. I am sorry about the storm on this slide, which is not cytokine release syndrome storm, actually. The severe disease, as Soumya already mentioned, that it is diagnosed on clinical grounds by the signs of pneumonia, which is fever and cough, with any of the following, with the respiratory rate of more than 30 breaths per minute, severe respiratory distress, and saturation of oxygen less than 90% on room air, that very amicably was shown by Professor Azizur Rahman on the plotting and comparing the saturation with the PaO2, that saturations of less than 90% have drastic effect on PaO2, which does compromise the function of the body systems. And then a very important component is that how much is the area of the lung involved. Then the chest X-ray involvement has to be more than 50%. And these patients, we know they have to be managed on high dependency unit, where high flow oxygen facility is there, where central oxygen supply is there, where monitoring facility is there. And these are the areas where we need to have non-invasive ventilation machines as well. And we need to have, if available, high flow nasal cannulas as well. The treatment in severe disease is supportive, and the mainstay of treatment here is oxygen therapy. And we titrate the oxygen therapy through the nasal cannula, to simple face masks, to non-rebreather mask, high flow nasal cannula if available, CPAP, leading to non-invasive ventilation. Then prone positioning for more than 12 to 15 hours is extremely important. I will very briefly touch all these components of treatment as we get along during the presentation. So proning of the patient, leaving the patient with the chest side down and the back up, or semi-proning, making the patient lie on right or left side for more than 12 hours is extremely important in improving the saturation in these patients and reducing the oxygen requirement. Enoxaprine indeed is indicated if D-dimers are elevated, and if D-dimers are below 1000 nanograms, then 40 milligrams OD is recommended. If they are more than 1000, then 40 milligrams BD of enoxaprine is indicated. However, if the D-dimer levels are way above 2000, then the therapeutic doses of enoxaprine are given at 1 milligram per kilogram every 12 hours. Antibiotics, I will reinforce Soumya's view and Aziz Sab's view that antibiotics especially on specific indications, and we need to set blood cultures and procalcitonin levels to look for any evidence of bacterial infection. Then remdesivir has been touched upon by Soumya, but I must reiterate that it is indicated in moderate and severe disease, and in those patients also requiring oxygen therapy, and regardless of if CRS is present. Remdesivir's licensed indication includes the prescription of medicine even if the CRS is present. And in case of cytokine release syndrome, then the steroids role has already been discussed, and we can use either methylprednisolone or dexamethasone in the light of recovery trial. And then tocilizumab is basically reserved in those cases where the steroids fail, and tocilizumab prescription has a very, very subtle place where it has to be used, and it has to be used with caution because it's a two-edged sword. overprescription of tocilizumab has been a major concern recently, and that led to the notion that tocilizumab has to be taken as an investigational drug, and we have to fill in a pro forma for the prescription of it. So I will very briefly touch on tocilizumab as well. So the severe disease, progressive or the critical disease, we need to have all the clinical features of the severe disease with any of the three manifestations. Number one, ARDS. Number two, multi-organ dysfunction and septic shock. If any one of these with above criteria of clinical pneumonia with oxygen requirement is present, we label these patients as having critical disease, and these patients are indeed managed on the intensive care unit. And the only difference in the management of severe and critical disease is that in critical disease patients, the oxygen is delivered through mechanical ventilation, and rest of the treatment in the form of remdesivir, in the form of tocilizumab, in the form of steroids, and in the form of anticoagulation is the same. Now, cytokine release storm is a very, very important predictor of the outcome of critically ill patients. In the presence of moderate, severe, or critical disease, we diagnose cytokine release syndrome in patients having lymphopenia of less than 800 cells per milliliter, or lymphocyte percentage on the complete blood count of less than 20%, or NLR, which is a neutrophil lymphocyte ratio of more than 5. If we have any evidence of lymphopenia with increased NLR ratio, then two of the following have to be present in order to diagnose cytokine release syndrome. Number one is ferritin more than 700 micrograms per ml and rising in last 24 hours. LDH value of more than 300 international units and rising in the last 24 hours. D-dimers value of more than 1000 nanogram per ml or more than 1 microgram per ml and rising in the last 24 hours. And CRP level finally of more than 70 milligram per liter and rising in the last 24 hours in the absence of bacterial infection, be that documented on the basis of blood cultures or that is documented on the basis of procalcitonin levels or overt clinical signs of bacterial infection in the form of polymorphonuclear leukocytosis in these patients. The oxygen delivery is extremely important in this setting, and we know that oxygen delivery can be done through nasal cannulae, simple face masks, through NRM, which is a non-rebreather mask, and high flow nasal cannula, which is HFNC. Nasal cannula has limitation. It's a low oxygen delivery system which can deliver up to 5 liters per minute of oxygen, which is akin to FiO2 of 28 to 44%. Simple face mask can deliver anywhere between 6 to 10 liters per minute of oxygen, which is akin to FiO2 of 40 to 60%. And non-rebreather mask can deliver up to 15 liters from 10 to 15 liters per minute of oxygen, which is akin to FiO2 of 80%. And HFNC has the maximum flow rate, and it can deliver up to 60 liters per minute of oxygen, which is akin to FiO2 of anywhere from 21 to 100%. So we can titrate the precise delivery of oxygen through HFNC, which is high flow nasal cannula, of the ratio of FiO2 of 21 to 100%. Nasal cannula and simple face mask and NRM are low oxygen flow systems, and HFNC onwards are high flow oxygen systems. So we basically move from nasal cannula to face mask to non-rebreather mask to high flow nasal oxygen if available, and then to high non-invasive ventilation, and then to invasive mechanical ventilation, which is IPPV. The oxygen therapy, which device to use and what sort of levels of oxygen are acceptable to us in the intensive care unit in critical patients. The recommended for SpO2 is less, oxygen is recommended for SpO2 of less than 92%. And any patient who's got oxygen saturation of less than 92%, oxygen therapy is indicated. And if SpO2 is less than 88%, it is shown to cause harm to multi-organs. And SpO2 of more than 96% increases resorption at atelectasis. So oxygen under correction is harmful and overprescription is harmful too. So it is important that we maintain the saturation of oxygen between 93 to 96%, and over enthusiastic increase in saturation of oxygen to beyond 96% has its own pitfalls, and it increases resorption atelectasis and can impair the tissue and can basically worsen the tissue hypoxemia. Non-invasive ventilation has emerged as a very important component of treatment in COVID-19 critical disease, and there is some evidence that it prevents the intubation rates, it prevents the use of mechanical ventilator through endotracheal tube. It may have a subtle use in resource-limited circumstances, and we have our own data of its use in our patients in Mayo ICU, where 111 patients were put on non-invasive ventilation, and these patients, out of these patients, 35 progressed on to intubation, and rest of the patients were basically prevented from going on to the invasive ventilation, giving a success rate of nearly 69 to 70%, which it does have and has a very subtle role in resource-limited places really where manpower is the issue, where the brunt of disease is very high, where the number of patients are very high. And Mayo at one point had 460 patients in one day, and 274 of them were basically in high dependency unit and in intensive care unit. So this put a huge burden on us really, and we resorted to non-invasive ventilation in these patients with very good results really. So this is a very good adjunct of treatment prior to putting these patients on mechanical ventilation. Now, the problem with non-invasive ventilation is that it does increase aerosolization of droplets. So the infection of the healthcare professionals is an issue here, but the modifications in the machines whereby you can put a filter on the exhalation limb of the NIV can minimize this risk really. And then if your ICUs have negative pressure systems really, or HEPA filters, we can minimize the droplet aerosolization and infection of the healthcare professionals really. And there is some evidence as it's a non-invasive ventilation, it may cause some barotrauma. Then high flow nasal cannula, which is HFNC, which is very much in favor. It has the potential of delivering 21 to 100% oxygen at flow rates of up to 60 liters per minute. This basically delivers oxygen through the nasal prongs, which are tightly fitting in the nose, and this delivers humidified, warmed air to the patient. So this is much better tolerated by the patients in terms of temperature, in terms of dryness of the nasal mucosa. But the problem is that this costs nearly 1 million rupees and is available in very small numbers in small centers in Lahore at this moment in time, and very few centers in Pakistan. We don't have any one available in Mayo Hospital at the moment, and that is what pushed us into using non-invasive ventilation by improvising of putting a filter on the exhalation limb and reducing the aerosolization with the success rate of nearly 69 to 70%. Now, high flow nasal cannula is much more comfortable than conventional oxygen because it's humidified, it's basically at the body temperature, and there is evidence that it does reduce the intubation rates, and a lot of centers in the world are using it at this moment in time. Whether it reduces ICU mortality remains to be seen. There's a question mark. We don't really know as yet. And it does increase aerosolization at flow rates of more than 30 liters per minute. So it does have the same problem as is the case with non-invasive ventilation without exhalation valve filter if the flow rate requirement is above 30 liters per minute in these patients. Now, the anticoagulation, Somia has had briefly touched it, and we have already basically had a brief account of it during the description of the severe disease. However, if the D-dimer value is the determinant of prescription of enoxaprine, or which can be substituted with rivaroxaban as well. If the D-dimer value is less than 1000 nanogram per mil, enoxaprine is given as 40 milligrams of per daily, and which is equal to 15 milligrams of rivaroxaban orally if the patient is able to take orally. And if the D-dimer values are above 1000, then enoxaprine should be given as 40 milligrams upward twice a day, and rivaroxaban equivalent dose would be around 20 milligrams orally daily. It is important that we check at baseline and daily the CBC, the INR and the D-dimer values, and guide the therapy, the dose of enoxaprine and rivaroxaban in the light of these results really. So it is basically, we can include all the patients admitted, all the admitted patients with moderate or severe or critical COVID-19 disease, and the exclusion criteria would be high risk of bleeding as judged by the treating physician. And we will hold anticoagulation when the platelet count is less than 50,000, or if the INR is more than 1.5 because of concomitant liver disease, or because of any other reason really. Or if there's evidence of current or recent bleeding, we will have to withhold anticoagulation therapy. Steroids have already been discussed and touched by Somia and Professor Aziz Sab as well. Recovery trial did show that 6 milligrams of dexamethasone works, and it works only in those patients who are on ventilator and who are requiring oxygen therapy. The usefulness of steroids has not been documented in patients who are not requiring respiratory support. So any patient who is not requiring oxygen therapy, who does not have severe disease requiring oxygen therapy, and any patient who has mild disease is not a candidate for steroids. And we can use dexamethasone 6 milligrams IVUD. This was shown in the light of recovery trial, which incorporated 2014 patients. Outcomes were compared with those of 4,321 patients receiving standard care, and steroid reduced mortality by 20% in patients on the ventilator and on the oxygen. And as I say, there is no benefit in patients who do not require and do not qualify for any respiratory support therapy. Remdesivir has been already touched upon by Somia, but the FDA has licensed this drug for use from moderate to severe disease to critical disease. So unlike many other drugs, antiviral drugs like the one that Somia mentioned, which is basically licensed, the license indication is in mild to moderate disease. Remdesivir has been basically licensed for use both in severe disease and in patients on ECMO or on ventilator as well really. So remdesivir has been shown to be of some benefit in these patients really, but again all the patients are not the candidates of remdesivir, and remdesivir will only be indicated in severe disease onwards. The role of tocilizumab, the tocilizumab being pushed into black market situation where an injection was being sold for up to 8 lakh rupees really, and it was being used in a very loose and indication actually. The criteria for the use of tocilizumab have been defined, and they are defined by the CIAG as well, and they have been defined by the health department as well in the light of criteria followed elsewhere in the world. It is basically based on the physiological condition of the patient, on the clinical parameters of the patient, and on the laboratory criteria. So we have 3 columns, one in the middle and one either on each side. First column basically shows a low physiological reserve due to if the patient is more than 60 years of age or has comorbid condition, which is cardiomyopathy if the ejection fraction is less than 40%, or if the patient has coronary artery disease, chronic lung disease, has had stem cell therapy or organ transplant recipient, or end-stage renal disease on dialysis. These are the patients where the indication of prescription of tocilizumab is looser, and you can basically give tocilizumab at slightly lesser indications compared to people who have good physiological reserve and who are under 60 years of age without any comorbid conditions. So if the patient is over 60 years of age and has comorbid conditions, we need to have either fever of more than 39 degrees centigrade, which is one of the subtle markers of cytokine release syndrome, or hypotension, which is a decrease in mean arterial pressure by 10 millimeters of mercury from the baseline, or progressive hypoxemia sufficiently severe to require 5 liters of oxygen to maintain oxygenation, or sustained respiratory distress as evidenced by respiratory rate of more than 30 breaths per minute. So patients needs to have, if the patient falls into comorbid with over 60 years of age, needs to have one out of these 4 criteria of fever, hypotension, requirement of oxygen, and respiratory distress as evidenced by 30 breaths per minute of oxygen. Plus, the patient needs to have biochemical criteria as evidenced on the right-hand column, any 2 of the following criteria that we have already discussed in the cytokine release syndrome, which is D-dimers, CRP, and LDH levels. So the patient needs to have 2 of these criteria. If the patient is under 60 years of age and does not have any comorbid condition, then all the 4 components of the clinical assessment have to be there, plus 2 laboratory criteria as outlined in the previous group of low physiological reserve, really. So we need to have 2 of D-dimers, CRP, ferritin, and LDH. Plus, we need to have fever, mandatory requirement, and with that, hypotension, 5 liters per minute of oxygen requirement, and sustained respiratory rate of more than 30 breaths per minute. And it is usually given as 4 to 8 milligrams per kilogram. For majority of our patients will require 400 milligrams on day 1, and we can repeat the dose at 8 to 12 hour intervals, depending upon what the response has been like. But the majority of the patients will require 2 doses of 400 milligrams of tocilizumab. And there are active contraindications if there is evidence of active TB, herpes zoster, underlying bacterial severe infection, sepsis, suspected GI perforation, multiple sclerosis. There is any history of allergy to tocilizumab. If the liver function RD rate and ALT is more than 5 times the normal, or there is hyperbilirubinemia of more than 2. If there is thrombocytopenia of less than 50,000, pregnancy is a relative contraindication, and if the potential benefit outweighs the risk to the pregnancy, it certainly can be used in pregnant patients. Then prone positioning is extremely important. Prone positioning means lying the patient on the chest side down and the back side up, or semi-proning position is extremely helpful. It affects by reducing the pleural pressure gradient from non-dependent to dependent regions, and hence it improves the ventilation perfusion. It reduces the physiological shunt. It leads to increase in the lung volume, so it basically increases the size of the volume which is available for ventilation. Redistribution of perfusion from the dorsal to the ventral areas, recruitment of dorsal regions, and more homogeneous distribution of ventilation is achieved by prone positioning, really. And it is recommended that in all the patients with severe to critical disease, prone positioning must be advocated and advised for more than 12 hours a day, depending upon the logistics and the patient condition. Then invasive positive pressure ventilation, if the patients fail a trial of non-invasive ventilation, if the patients fail a trial of high flow nasal cannula, then we resort to lung protective ventilation, which is intermittent positive pressure ventilation. And the general principles are that we give a tidal volume of 5 to 7 mils per kilogram, which are lower tidal volumes. We have to maintain the plateau pressure of less than 30. The driving pressure, the initiating pressure, which is basically the plateau pressure minus PEEP of less than 15, which is extremely important in order to reduce the baro and aerotrauma to the lungs. The target saturation of oxygen that has to be maintained is between 90 to 60%. Don't compromise on saturations below 90%, and don't compromise on saturations of above 96% because of the atelectasis and because of the hyperoxygenation induced trauma to the lungs, which is like we have to maintain the partial pressure of oxygen in the ABGs of more than 60 millimeters of mercury. The starting PEEP is at 8 to 10 centimeters of water. We can always increase it to 12 to 14 centimeters of water depending upon what the oxygenation is like. And as I say, prone ventilation for 12 hours per day. There are 2 phenotypes of lung presentation in critical COVID-19 disease. One is called as L phenotype and second is called the H phenotype. L phenotype is the distribution of ground glass shadowing in the lungs on high resolution CT scanning or on the X-ray of the chest. L stands for low lung elastance. So L type is the type where there is scattered ground glass infiltration. The ground glass infiltration is less. There is paucity of ground glass infiltrates. Ground glass infiltrates are scattered here and there on the CT scan. And this is called as low lung elastance situation, but a high compliance situation. This type of phenotype is not very responsive to PEEP, and hence high PEEP levels are not indicated in this setting. And these are the patients which are less dyspneic clinically. So L phenotype is low lung elastance, but high compliance, scattered and less ground glass infiltrates, low response to PEEP and less dyspnea. And the ventilatory strategy in these patients would be to use lower PEEP. We normally use less than 10 centimeters of water PEEP in these patients. And we have the liberty of using more liberal tidal volumes here of 7 to 9 milliliters per kilogram, because we have to overcome higher compliance. And we have to reduce the oxygen demand of the patient by considering these patients into prone positioning. Perhaps prone positioning in L type is not that important as is it's important in the H phenotype, which is characterized by high elastance, which is akin to low compliance, which is characterized by extensive ground glass shadowing on the CT scan and on the X-ray, which is basically responsive to high PEEP. And these patients are very overtly dyspneic, and they are basically struggling for the breath. And these patients, the ventilatory strategy is slightly different to L phenotype, where we use higher PEEP, but usually between 12 to 15 centimeters of water, not beyond 15 centimeters of water, because of the barotrauma it can induce and because of the hypotension it can induce. And we have to use the lower tidal volumes here because this H phenotype very closely mimics the typical ARDS picture that we come across in non-COVID patients, where we end up using low tidal volumes. And in these patients, implementation of prone positioning is of pivotal importance, and it does reduce the FiO. It does reduce the FiO2, and it does reduce the symptoms of the patients really. And in any patient and where the invasive mechanical ventilation, the IPPV fails, we have the option of ECMO. Unfortunately, ECMO is not available in Punjab at this moment in time, but there is a lot of data available in the favor of ECMO in supporting these patients when they have failed a trial of IPPV. Rather, in some situations, ECMO has been applied in early stages of IPPV as well, with very good results. And on April 7, 2020, FDA approved ECMO as treatment of COVID-19 disease in patients in whom the satisfactory oxygenation is not achieved on IPPV. ECMO basically is a dialysis of the lungs, really, like we do the dialysis on the kidneys. It's dialysis of the lungs, that we make the venous blood pass through the machine and enrich it with oxygen and re-infuse it into the patients, really. And this has been shown to be of great benefit. And I'll break here. Thank you very much. Over to you, Asma.
Thank you, sir. Such a comprehensive and detailed treatment under serious cases. Now we come to the end of our webinar. This is already quite late, but we'll still have a few questions. Anybody from the faculty, from the professor, if you want to give any comments, any questions from our presenters. Okay, I think lots of students have been asking the questions on chat, and they have been answered by the presenters. So,
if you allow me, there have been a lot of questions about the breaking of isolation and when to retest the patients. So,
yes.
If I can just tell you the discharge criteria and criteria for these patients who are asymptomatic but are in home isolation, when they are safe to, to be sent home. For people who are asymptomatic, 10 days from the date of positive test. This is the criteria, that when they have reached the limit of 10 days, this is the time-based strategy. And if they were symptomatic patients, then at least 10 days. And if I can just show you the slides, can you see the slides?
Yes.
Okay, so if patients are asymptomatic, then this is 10 days. But if the patients are symptomatic, then at least it should be 10 days and 3 days after resolution of symptoms, that is fever without antipyretics, no or improved respiratory symptoms that like cough or shortness of breath, they should be settled for the last 3 days. Then you can send these patients home even without testing. The previous recommendation was to get 2 tests 24 hours apart. But now you can send them home and label them cured even without testing. But there is an exception for healthcare workers, for people who are immunocompromised, like cancer patients or autoimmune disease patients or patients who are on long-term steroids or immunosuppressants, or people who are living in congregations like hostels, community livings, madrasas, and prisons. They need to be tested 2 times for PCR 24 hours apart, and if they are negative, only then they are to be labeled as cured and discontinue isolation. So this was just one thing which was left, so I thought I would just share it with the audience.
Okay, thank you, Soumya. I think that should settle a lot of confusion for the students over here. Anybody else? Any questions, any comments that you would like to give? Okay, then I think I would invite Professor Farooq Zaman to please give his comments on this webinar.
Thank you, Asma, for calling me in. Let me begin with congratulating Professor Azizur Rahman for organizing this excellent webinar, and all the speakers and presenters, starting with himself, and then Soumya, Professor Tahir Masood, Professor Abul Fazl, and Professor Saqib Saeed. Each one of them has been an excellent presenter, and in their own specialty, they have excelled, and they have done a wonderful job of making everyone understand and simplifying things and bringing about the essential information for the health professionals. I'm sure all the participants who had the privilege of listening to them and seeing their slides must have learned a lot about this evolving, it is still evolving disease process. And the way they have presented in the authentic manner with the evidence that would dispel many of the myths, even amongst the medical professionals. I just wish that this webinar had a greater and larger audience, so that many of our colleagues in the health profession, they would have benefited from that. Professor Azizur Rahman, as always, excellent slides with the confident and simplified presentation of the material. Soumya Iqtidar, I've had the pleasure of attending one of the presentations regarding dengue at RLMC. She was there some times ago, and she's an excellent presenter in that respect. Thank you very much, Soumya, for sparing time here.
Thank you very kindly.
Masood detailed the current status of COVID amongst the pediatric patient population. And I think it was a very comprehensive coverage of the subject. Professor Abul Fazl, he pointed out many problems that the surgical specialists or those who are in surgical specialties they come across, and the essentials of avoiding contracting the infection, and also of spreading the infection by the surgical teams. I think it was a very relevant presentation in a concise manner. Then Professor Saqib Saeed, whose presentation earlier on got some hitches, but I was thinking during his presentation that it should be the people in the intensive care units and all those who are managing critical COVID patients, that they should, it appears that he has been treating COVID patients for the last many years, although it has been there only for a few months. But the detail and the confidence with which he has made his presentation, that was unmatched. Congratulations to Professor Saqib Saeed and all the other presenters. We were privileged to be part of the audience. Thank you very much.
Thank you, Professor Usman. Now I would like to invite our beloved Professor Rashid Latif Khan for this concluding remarks on this webinar. So over to you, Professor Rashid.
Thank you very much. Bismillah ar-Rahman ar-Rahim. First of all, whatever Professor Farazman has said, I totally agree with him. His English is better than mine, so I can't even add one word to his comments. And totally agree with you, Farazab. But still, I would like to say 2 or 3 things. First of all, I must congratulate Principal Professor Tahir Masood Saab, because the captain gets the credit. Only yesterday I saw on television, Messi has scored 700th goal, but the credit to the club. So similarly, credit to the club of Rashid Latif Medical College and Principal Tahir Masood Saab. Second, without Professor Azizur Rahman, the medical department in the college would be grossly incomplete. The way he contributes to continued medical education is exceptional. Is exceptional. I must compliment him, and I hope and pray he continues doing this. The only comment I can make is perhaps this seminar should have been held 2 months ago, because I feel there are a lot of misconceptions within medical community about the management of COVID patients. And the way the subject has been covered by all of you is excellent. I would rather say somebody amongst you, if nobody else than Farazman, he has access to Dr. Faisal Sultan, the person who is kind of coordinating all the activities of COVID patients with the Prime Minister. You should pass this seminar in a documentary form and ask him to distribute it to all the medical colleges or all the big hospitals taking care of COVID patients, where this should be shown. It's only 2-hour seminar, and I'm sure every hospital, every medical college can spare 2-hour seminar for spread of this good knowledge and the keeping the up to date how to manage their patients. It's a great service. It's a great service. I mean, the way Abul Fazl described the care surgeons should take and their team should take is important, because when this disease became sort of endemic and pandemic, the health carers were scared of it because they were getting infection because of absence of proper precautions. But when the proper precautions were taken, the spread of infection to the health carers reduced. So it's a matter of taking proper precautions. Whosoever, whether in the emergency, in the ward, in the surgeons. So it's so important that we should pass on this information to the ministry in Islamabad and make a request that pass this seminar to all the medical colleges, all the hospitals taking care of the patients. And well, right from Azizur Rahman, the way he introduced the disease or the problem, then care of the patients, the way Sonia described, and then came Professor Tahir Masood. I'm glad he touched the passing of disease in a pregnant woman to the fetus or not. that was important information as well, because a lot of pregnant patients, they get the disease and they are worried, they are scared. So all the way it has been covered by all the speakers is beautiful. Last of all, Dr. Saqib said he wanted to be a gynecologist, but somehow he didn't. After listening to him, I feel it is a great loss for gynecology that he didn't come in. I wish he had done that. It would have been a great contribution to our specialty, because we do need good people. Every specialty needs good people. But somehow, in the old times, the best students used to come to gynecology, but now there are other options available, which is 9-to-5 job, less stress, less work. So we are getting the best. Sir, we miss you. And before I close, you people kept talking about oxygen, 93% and all that. Farah knows, I always had oxygen 95%. Somehow I never got it seriously investigated because it doesn't bother me. But when I have been admitted twice or thrice to the hospital, I always tell Farah, कोई चीज खराब होए तो उन्होंने दस नहीं मेरी ऑक्सीजन नॉर्मली नहीं हुंदी है and my heart rate resting heart rate is about 50-51, so that's close to bradycardia. So my heart rate is close to bradycardia, my oxygen rate is close to the level which worries the physicians, but I'm doing okay. I am all right. So it's not one figure, one oxygen level, one heart rate, which should decide the matter. Is the whole picture, Thank you very much for asking me to make these comments. I compliment you all again, and please do consider my suggestion of reaching Faisal Sultan. Thank you.
Thank you so much, Professor Rashid Latif Khan. It's an honor for us to listen to you always. I would like to thank all our speakers, Professor Azizur Rahman, Dr. Sumi Iqtidar, Professor Saqib Saeed, Dr. Tahir Masood, Professor Abul Fazl Khan, Professor Farooq Zaman, as always, all our respective faculty members, professors, and our dear students for making it a very successful webinar. Thank you, everyone. Bless you.
Thank you very much, sir. Very kind of you.
Thank you. Thank you.
Thank you.
Thank you.